We're really excited to have Dr. Heather Ene with us today. She is actually part of a group of people who are active in trying to bring Dance for PD to Denver. She's a former dancer herself, although currently does the tango, she tells me. And she is a physiatrist. I had to look up that term when I saw it in her bio. And it's someone whose specialty is in rehabilitation of people with dysfunctions of the neurologic system. She's also a movement disorder specialist, and her areas of interest are balance, gait, and pain in Parkinson's disease. And she sees patients at the University of Colorado Hospital and also at the University of Colorado Family Medicine Clinic in Boulder. And she's speaking to us on pain today, pain in PD, a subject with which most of us are quite familiar. So with that, Dr. Ene.
Thank you. I'll try not to blow out anybody's ears again. Okay. So, pain in Parkinson's disease has been recognized for a long time, but it's really more recently that people have been concentrating on it and talking about it more broadly. And the literature has started to become a little more robust over the last 10 years, I'd say. But what my goals for this is to help you to recognize the spectrum of pain syndromes that occur in Parkinson's disease and to understand the terminology that the medical community uses in trying to understand where the pain might be coming from, and it might facilitate your discussions with your healthcare providers so that you get the best care possible. And then talk about how the Parkinson's medications might influence pain and what other strategies there are to address it. It turns out that pain is very common in Parkinson's disease, depending on how it's assessed. The estimates have ranged really from 30% to 75%. But this is even if you ask somebody currently, are you having pain, that they'd say, yes, I'm having pain. And that's high above what the general population would report when we ask people age matched to Parkinson's patients. And the pain varies in location and quality and origin. In younger onset Parkinson's, dystonic pain, cramping and twisting postures predominate. There are many ways to look at pain and discuss it, but this is probably the most common classification system, the Ford classification. And so I want to explain a little bit about the terminology here first. So central pain or primary pain means it's related to the Parkinson's disease. It's part of the neurodegenerative process, and it's not, and it just arises on its own because of what's happened in the nervous system. It's not a secondary phenomenon. Secondary pains include these four types, meaning that the Parkinson's may contribute to that pain. But there's a structural problem that's going on, such as arthritis in the knee or back pain. There's a structural problem there, but the Parkinson's might add to it and make it worse. And so those are described as musculoskeletal, neuritic or radicular, so a peripheral nerve such as the ulnar nerve or the median nerve as in carpal tunnel syndrome, or nerve root when people have sciatica, that kind of pain is radicular, so nerve root, radicular. Dystonic pain is what I was describing. So dystonia is an involuntary cramping or spasming of muscles, tends to create a twisting posture that may be sustained or it might be transient, just come and go. And then akathisia is a funny one. That's an internal sense of restlessness, like you just have to move all the time. It's hard to sometimes differentiate from restless leg syndrome, but that starts at night and then may move to the day after a while. But akathisia is all the time. And that may be related to a medication, or it may be primary related to the Parkinson's itself.
Could I ask a vocabulary question?
Yes.
It sounds like some things we don't typically label as pain. And the restless leg, for instance, I have that, and I don't consider that pain. How would we tell what you're categorizing as pain and what we think is something else?
Well, you can have unusual, abnormal sensory feelings, and if they're unpleasant, that would be considered pain, particularly if they're affecting the quality of your life.
Thank you.
Or function, So I'll talk about these more in depth, each individually, these classifications. But to just explain this a little bit, there is a subclassification mostly related to medication cycles. So it's important for me as a physician in trying to understand the pain to know if there's any correlation to the medication on phase or off phase, and so particularly for the central pain, for example, there's off period pain when they're in the worst off, beginning of the dose as it's just coming on, peak dose, end dose. Those sorts of things matter when you're trying to understand it. And then in the musculoskeletal category, is it pain just due purely to Parkinsonian rigidity, or is it an underlying rheumatologic or musculoskeletal disorder, or are they both, adding to each other, which is mostly what happens. And then I explained the neuritic radicular. So these are also related to on and off cycles of medicines. So this primary central pain, it might occur in up to 30% of people, and there's no tissue abnormality. You can't find. It's not because there's a degeneration in the elbow or something like that. And it tends to be this difficult to describe discomfort that it might seem weird. It might be hard to even find a word to describe it, crawling or creeping or itching or gnawing, but it doesn't tend to follow the pattern of what we recognize as a nerve root or of a, it's not a very, often it's not exactly in a pattern that we can ascribe to a particular tissue that's been irritated. And it can be a sense of tension. Some of it is, it can be, you can have funny oral feelings, or genital pain also has been described in Parkinson's. So it's felt, as I said, to be a consequence of the disease itself, and it might even precede the onset of the motor symptoms, which is generally when Parkinson's is diagnosed. And it has, in a number of studies, it appears to be worse on the more affected side if there's an asymmetrical onset in the Parkinson's. So the more motor affected side, the slower, more rigid side might also be more painful. And for a lot of people, it seems to be more severe in the off state. So this is really technical, but the idea, so in Parkinson's, the main system that undergoes degenerative changes is the dopamine system, a neurotransmitter system, but there are other systems that also undergo changes. And so it's felt, based on observation of how people respond to medicine and testing, that there's probably a component that's related to degeneration in the dopaminergic side, and there are non-dopaminergic changes that contribute to the pain. This is central pain I'm talking about, this primary pain. So the motor planning, deep motor circuits include these nuclei, these tight nuclei in the deep brain called the basal ganglia, and they talk to the thalamus, which then talks to the cortex, so there's a loop there. So there may be some problem in that loop. There are also, even though we think of the basal ganglia as being more of a motor control area, there are sensory integration properties to the basal ganglia. And so there's some thought that there's some screw up in the sensory integration and some trouble with muting pain signals. And then there's also a theory that there's degeneration in the brainstem as it talks to the limbic system, which controls our emotions and can control the perception of pain. And all those areas are being looked at. So because there's maybe some dopaminergic system component to it, some of the medicines such as Sinemat or Mirapax or Requip, which are dopaminergic medications, or amantadine, which boosts the dopamine levels, That's dopamine replacement therapy, that DRT, and I use that abbreviation a lot, so that's what that is. So that might help with some of the pain, and that's why it's really important to optimize the Parkinson's treatment, because that might help, but also keep in mind that it might make it worse sometimes. Then there are others. These are generally antidepressants, these norepinephrine reuptake inhibitors. This is actually a blood pressure medicine that works on the sympathetic nervous system, this clonidine. And then there are nerve pain medicines that we use a lot for various things. But people try lots of different things, opiates, neuroleptics or antipsychotics, probably not the best thing to use. But people have tried a lot of things. The problem with Parkinson's, and you may or may not have seen this, is that I think providers are reluctant to give some of the medications that could be helpful because of the worries about sedation and falls and confusion. And a lot of these medicines have side effects that could be problematic, and that may be partly why Parkinson's pain is undertreated. I think because providers are worried about the side effects. So there are some studies. I think that probably if I dug further, I'd find some more small studies of deep brain stimulation surgery, both in the subthalamic nucleus, which is mostly where we target, or the globus pallidus internus, that might help relieve this kind of pain. But peripheral nerve blocks, like the anesthesiologists like to do a lot of these nerve blocks, so far haven't been shown to help this pain. It's more central nervous system pain. So talking about these other types, so what might contribute to musculoskeletal pain? Well, it may be that some of the rigidity or decreased movement, joints like to be moved a lot. They need to be moved a lot. If they don't, they start to undergo changes. So the lack of movement could be a problem. What I mean by deformities are these dystonic postures that people can kind of get into, especially a foot. Like a foot, you may or may not have seen this with a foot turning in like that. So that kind of thing, postural abnormalities which put stress on tissues. When you're leaned over like this, or you have dyskinesias and your neck is twirling around, that's not so good for discs. That's not, probably not good for these facet joints. It's not good for those tissues necessarily. And so that's the dyskinesias here. Mild dyskinesia is probably not a problem. Where am I? Here. It's failing. Anyway. So people not sleeping well, not having restorative sleep can be a problem. Depression may add to that. But in the musculoskeletal pain does seem to wax and wane to some degree with the medication cycle. Shoulder pain is an interesting one because there are a lot of people who've had shoulder surgery before their Parkinson's was diagnosed. And it's not necessarily the case that it wasn't